Good. Thank you. I'm Marie Violet. I'm director of the Health and Wellness Center at Sequoia Hospital. And we were so pleased to be invited to be with the village this morning to talk about the discharge planning process at our hospital. But I think you could use these suggestions to get ready for something that you hope isn't going to happen, but it's things to think about in your planning. So thank you for inviting the staff, and we have the care coordinators, we have the social work department and health and wellness. And without further ado, I'm going to turn it over to Matt Payden, who will start our presentation. And we froze.
All right, can you hear me? Okay, I'm Matt Payden. I'm an associate clinical social worker here at Sequoia Hospital in Redwood City. I'm also a substance use navigator for people experiencing issues with substance use. I work in the care coordination department, where we also focus on safe discharge planning. Also on this call for questions later is our Director of Care Coordination, Sansan Tu, and our Supervisor of Care Coordination, Bang Dong. They're both licensed clinical social workers and have been doing this forever. So they are a great wealth of knowledge. Okay, we can go to the next slide. So basically, I'm just going to give kind of a brief overview of safe discharge planning and what we do on our end, and just some things for you to expect or people to expect when they are inpatient and next steps. So basically, safe discharge planning is all about providing the right care at the right time in the right setting. We can go to the next slide. So sorry, my picture got deleted. It was a picture of the cast of Grey's Anatomy, which I do consider to be my first education in healthcare. I learned many medical procedures from them. And so this is just a definition of transition planning. It's a process used to decide what a patient needs for a smooth move from one level of care to another. It's done by a social worker, a registered nurse, case manager, and it includes moves from hospital to a nursing home, to home care. Discharge planning also includes services of home health agencies to help with the patient once they're at home. So that would be physical therapy, occupational therapy, and social work services if need. Next slide. So a really important part is the groundwork and the foundations of discharge planning. So basically, it's an identification of patient needs by an experienced interdisciplinary team, which is the RN, social worker, case manager, doctor, everyone. And so what we want to do as a team is define the least restrictive environment that can meet the patient's needs, because we want them to thrive in that environment, which is the next step. We always include the patient, the family, a patient representative in the whole discharge planning process. We're huge about advocating for yourself and telling us what you want as well. And we'll always educate the patient representative and family about community resources as well, so they can reach out to different agencies for themselves, such as SCIP and home health and things like that. Okay, next slide. So discharge planning really is a process, and I try to lighten it by making me think of like baking brownies, you know, like there's all these moving parts. And when we bake a brownie, we want to make sure it's like crispy on the outside and still like gooey and warm on the inside, which is the perfect brownie. And so we want to identify at an early stage of hospitalization those patients in need of discharge planning and even more complicated discharge planning. So right off the bat, we're going to provide a discharge planning evaluation, which is an assessment of your needs. And that's going to be upon the request of the patient representative, family member, physician. So we complete the evaluation, boom, right off the bat, so that everything is in place prior to the discharge. we try to avoid unnecessary delays just because we want to make sure that you're getting the care that you need at the right time. And if you spend too long here, you may not be getting the physical therapy and things that you need. So we developed a plan under the supervision of a registered nurse, the social worker, and other qualified personnel, the MDs. Next slide. Just our standards. Standards are very important. So identification of needs, the evaluation or assessment, the plan that we make, the transfer, which is then we want to make sure everything's in place for your safe transfer to your next place that you are going, whether it be home or a facility. And then a reassessment right before you will discharge, just to make sure it's all there. And next slide. So transfer agreements, not so much an agreement, but an assurance that you are going to a place where you're getting the care that you need. So it's basically transfer of patients will be affected between the hospital and skilled nursing facility, acute rehab. And this is when the MD will deem the patient medically stable for discharge to the next place. Next slide. So continue, there'll be an interchange of medical and other information necessary or useful in the care of the patient to the next facility, whether it be a skilled nursing facility, acute rehab, long-term care. And we want to make sure that we have all the information so that they can have all the information as well. And yeah, next slide. So this is just something kind of a need to know is, so post-hospital extended care, when a patient is going to transfer to a nursing facility, it's generally mandatory for Medicare patients that you require a 3-day stay in the hospital so that we can gather all the right information when you do transfer to a skilled nursing facility. A 3-day stay, however, is not needed if the patient is discharged to an acute care rehab, which is a shorter stay with more intense physical therapy, or a long-term care hospital. And the goal is to make sure that your 3-day stay doesn't turn into a 3-hour tour, like the Gilligan side. So next slide. Another thing I like to remind patients is, EMTALA, which is an Emergency Medical Treatment and Active Labor Act, things to know for yourself, that hospitals must provide medical screening examinations, treatments, and transfers of individuals with an emergency medical condition or women in labor, regardless of the ability to pay. So go to your closest emergency room if you feel the need, Next slide. And a little continuation of the EMTALA is the hospital will always provide an appropriate transfer if the hospital is unable to stabilize the patient within its capacity, or if the patient requests. Next slide. This is about your Medicare and hospital discharge. So beneficiaries of Medicare, primary, secondary, or tertiary, who are inpatients, do have the right to appeal to their state for a review when a physician determines the inpatient care is no longer necessary. So that's why it's also so important to have a patient representative, a family member with you, because if someone or you feel that you're not actually stable for discharge, you can appeal to your state to say, I'm not ready to go, even when the physician deems you medically stable. Okay, we want to make sure that you feel safe as well. And next slide. So another, important to know of your appeal rights. We actually do provide these important messages from Medicare, which will be signed by the patient representative, or a family member. And hospitals will issue these and explain the important message from Medicare within 2 calendar days of your admission and obtain that signature. And then again, hospitals generally must provide the second important message from Medicare within 2 calendar days of the day of discharge, not routinely on the day of discharge, but within 48 hours. All right. And just a little continuation on that. Beneficiaries do have until midnight of the day of discharge to appeal and be responsible for only the coinsurance and deductibles until noon of the next day. And that's after the quality department notifies the beneficiary of its decision whether your appeal is denied or accepted. And beneficiaries can still appeal after midnight of the day of discharge, but then can be charged if the appeal is denied and they stay past the 24 hours. All right, next slide. So another really important thing is I just think proactive discharge planning is the best type. A team is so important. So I want everyone to always think of like their case manager and themselves as a team. We're working together to make sure that your discharge is successful. And one of my favorite teams here is the Odd Couple. So again, discharge planning starts on admission. It is imperative that case management evaluates and coordinates discharge planning early in the process, just so it's the safest discharge possible. Some included payers in the discharge are obviously your available benefits, the co-pays, your preferred providers, whether that be a home health provider, and then just certifications and authorizations and kind of the paperwork part of that. And next slide. So we also want to make sure that we're promoting satisfaction to the whole team. So proactive discharge planning also leads to satisfaction. So with the patient, with the family, number one, most important, as well the physician, the nursing department, the community partners that you will be working with post-discharge. And also this just always leads to improved outcomes and reductions in any delays or denials. Okay, the next slide. And why we plan and why we make it so imperative that we plan early for these discharges is we want the patients to also reimagine themselves as sufficient and satisfied and create wellness goals and aim for mental images to sustain that recovery post-discharge, so that you feel good. And next slide. And so basically my advice is always, if you do become inpatient, ask for your case manager right away. We're here to answer the questions, advocate for your choices, and support you in all your next steps while you're here and post-discharge. And we always stay available whenever you need us. So, okay. And next slide. All right, thank you. And I'm sure there's some questions, so please.
I'll ask a question. Tell us about some of the most successful discharges that you've seen lately and ones where you would have hoped it went differently.
Okay. One of our most successful recent discharges that I've seen was a patient that was actually discovered on a city bus. She was very sick, vomiting. They were then brought to the hospital by the paramedics. The patient was unable to identify themselves. We then admitted them. We couldn't find any family because all we really had was a name of the patient, which we found on like a city bus card. So basically we made it our goal. We wanted to find family. We needed to find someone to advocate for this patient, a representative. And that because the patient could not advocate for themselves, we basically just made a list of places to call, and looked at where they came from. Like we found out that the patient was actually coming on a bus from San Jose going towards San Francisco. So we looked at that. We ended up phoning police stations, shelters, anything we could find. And amazingly, on day 3, we found a birth date that could possibly be the birth date of that patient from a police station. Then we found another system where we looked at the patient's name alongside with the birth date, and we found another piece of information. And eventually all of this led to us finding one of the patient's children who lived across the country. And now the patient and the child had, didn't have a relationship at that time. However, we were still able to find someone that could then advocate for the patient and give us a little more information. And we finally found out basically what the child, who was the next of kin, believes the patient would want. And we worked with the child to find next steps for the patient. It was a great sort of like reuniting as well for the patient's son and the patient. And yeah, so it was very successful. It was kind of like a CSI,
It does sound movie-like, yes.
Yeah. So that was a successful one that I think we were all really proud of. And we really dignified the patient as well in that way, so. And one that I remember where I was a little upset with the outcome, the immediate outcome, it was a patient that really wanted to discharge home. And they knew that they were at a point in their life where they probably weren't going to live for too much longer. And they wanted to be at peace at home. And we wanted to dignify the patient with that. And I was very adamant about letting the patient go home with home health. Even though we couldn't get 24-hour care, the patient kind of assured us, no, this is fine. Will be enough care. I know that I can get around on my own, and I just want to be in my own house, which people want to be in their own house. That's your comfort place. And so we did end up discharging the patient to their home. And I think it was maybe 6 to 10 hours later that they were back, because they very quickly discovered that they couldn't even get to their own phone if needed to be at their own phone. They didn't have the mobility that they thought they had, that we hoped they were going to gain, and so but we also were so concerned with dignifying the patient. So that was something where I thought we should have, there could have been some additional steps rather than them coming right back. And then the patient did eventually discharge to a facility where they had 24-hour care.
Mm-hmm. We have a question from Emily, and she says, if you live alone and have no near relatives, who can act as an advocate?
We can do, well, that's when you can kind of find a patient representative. You can always find a friend, or we have an ethics team here, which can also work as advocates for you. If you just truly feel like there is no one to advocate for yourself. And we, especially in the social work department, we really make it a point to look at what the patient needs and how to dignify them. So,
and I would add, I was going to say that I'm not sure if I can say advocacy, but I know that one of the village services is to have volunteers join members for medical, appointments. So I don't know how that is for the hospital stays, but I would imagine that there's some ability to have people help out from the village community as well.
Yeah, we welcome and really appreciate our patient representatives and anyone advocating.
Anybody else have questions or want to relay a good experience or an experience that they learned from?
Devora, I'm going to have Nora go next, and then so people can think of questions, and then we can loop back for questions.
Perfect.
Okay.
Hi, thank you for having us. My name is Nora Wang, and I'm the Community Health and Transitional Care Nurse here at Sequoia Hospital. Everybody can hear me, I hope. Yeah, okay. So I'm commonly known here as Skip Nurse, but my official title was I am the Community Health and Transitional Care Nurse. So next slide. So what do we mean by transitions of care? Matt touched on it already in one of his slides. So transitions of care is simply the movement of a patient from one setting of care to another. as their conditions of care, their care needs change. So it could be from hospital discharge to home care, hospital to skilled nursing, hospital to acute rehab, et cetera. Obviously, during these last 2+ years of the pandemic, you can imagine how difficult it was for patients who were returning home during the COVID pandemic, and it presented a lot more challenges for everybody. Next slide. Okay, so what I kind of want you all to get in the mindset of is, you know, obviously, if you have a planned elective procedure or surgery, you do some advanced planning, and versus having an unplanned admission to the emergency department. So again, thinking ahead of something more fun, like when we're planning a trip or a vacation and we're all excited about this, we have to consider many different things for a trip. Like, first of all, where do you want to go? Who do you want to go with? When do you want to go? And how are you going to get there? And then that's going to elicit another set of questions that you need to consider in planning your fun event and trip. So that entails, okay, depending on the time of year you're going, what will the weather be like at your destination? And then that's going to entail more questions of, depending on the weather and where you're going, what are your plans when you get there? What will you be doing? What kind of clothing will it dictate, depending on the weather? Different types of shoes, et cetera, et cetera. So the idea is always planning ahead and so giving it some forethought. So I want people to have a mindset of thinking about discharge planning, and not so much when you're going to be admitted to the hospital for your presumed elective procedure, but more importantly, actually almost, what will you have to do to plan for your discharge, and particularly if it's discharge home? So things that you need to think about and consider are, what is your current living situation? Do you live alone or do you live with others currently? Do you have any local family, friends, neighbors, faith-based organizations who can help you in your early transition to home care? Also, you know, medications are very important. And I want patients to think about, how will you get your medications? Does the pharmacy that you use, do they have a delivery service available? Here at Sequoia, we do use Now RX, and they do home deliveries. So it's clearly advantageous to have your medications delivered to your home or arrive to get to your home before you do, or as you get home, so you can start immediately taking them properly, correctly. Also, you need to think about, obviously, food. So again, if it's that planned elective procedure, you know, it's probably wise to think about planning meals for at least the first week of the early part of your recovery, and stocking up on either non-perishable staples, frozen foods. Can you rely on the kindness of others, your church groups, any support groups? You know, if you have, if you're blessed to have some local family around, they can help supply a couple meals, you know, in that first week. Next slide. With essential checklist continued, you also need to think about your transportation resources, because you will need to be making follow-up appointments with your primary care physician and or other specialists. So if you currently were not driving, or you don't even own a car anymore, who's going to be your driver? Once again, do you have local family, friends, neighbors, caregivers who will be able to transport you to and from your follow-up appointments? If you don't have family help, then you're going to have to rely on alternative transportation resources. So for example, you know, Lyft, which the number is listed here, which is now part of Peninsula Volunteers. And you also obviously have to be comfortable using this type of transportation. Now, if you are currently a Ready Wheels client, that's already coordinated for you. You know, they will be able to pick you up and take you home and get you to your appointments. Generally, they do focus more on medical appointments. There's another service available called FISH, which is Friends in Service to Humanity, and their number is listed. And now the FISH, they're currently managed by you guys, the Villages of San Mateo County. So they're a wonderful resource as well. Also, you need to be thinking of caregiving resources. Okay, and this is obviously going to be very important. And once again, you're going to have to reflect on what your current living situation is. Who's going to help you in your early recovery? How much care will you need? Now that can be an unclear question at the time of discharge, I think sometimes, because obviously one doesn't necessarily know how much care they're going to need. You know, there's many factors that are going to contribute to that. There are, but if you live alone and you really have limited to no outside resources, you know, you may need to consider hiring private duty caregivers. Now there's many agencies here on the peninsula, but they all are going to be private pay. So if you end up having to hire private duty caregivers, know that this is not a covered benefit under Medicare or any other commercial payers. It is self-pay. And as we know on the peninsula, and particularly nowadays, nothing's inexpensive. Okay, and then the next thing is you need to give consideration, of course, to your follow-up care. When you get discharged, you will have an order to follow up with your primary care physician and or any other specialists, neurologists, cardiologists, pulmonologists, gastroenterologists, etc. Will you be scheduling your own appointments, or are you going to need help scheduling from others, family members? And obviously, if you're going to need help probably scheduling your appointments, then you're going to need a driver to take you to and from, because obviously you're not going to feel well enough if you were driving before the admission to be driving yourself to and from the hospital. Finally, you do need to think also about your technological capabilities, particularly obviously with the pandemic that we all had. We're all familiar with how everything shut down and everything went to Zoom, virtual appointments, televisits. So do you have internet capabilities at home? Do you have a smartphone? Do you have tablets? Do you have a computer? Because these are all going to enable you to, you know, either do virtual appointments or at least a televisit. Next slide. So the care coordination team, which Matt is a part of, consists of, as he mentioned, registered nurses and social workers, predominantly case managers. So when you get discharged from the hospital, you will get discharge instructions. Please review your discharge instructions before you leave the hospital, or have your designated support person review it with you. So obviously, if you have questions or concerns, or something's not clear to you, you can have those concerns addressed while you're still in the hospital. Now, your instructions, you will be told, obviously, if you have or if you're in need of home health services, that will be ordered by the hospitalist. And that will tell you, you know, did they order a registered nurse for you, a physical therapist, an occupational therapist, a social worker, a home health aide? Do you need DME, durable medical equipment? And that would be, obviously, I think you're all familiar with things like walkers, canes, bedside commodes, elevated toilet seats. And there are nonprofits like the Medical Equipment Project through the Belmont and Redwood Shores Rotary Club, Rotary. And I also, you know, have used CID, which is the Center for the Independence and Individuals with Disabilities, to name just a few, again, local nonprofits that will are able to supply medical equipment at no charge. And they do their own cleaning and their sterilization, and they get donations from people who no longer need them. The other thing you want to work with your care coordination team and on your discharge instructions, obviously you will have discharging medications. Some of them may be new to you. some of them may be adjusted. So the hospitalist, the doctor needs to make a slight change in your current medications. Maybe they need to lower the dose of one or change the frequency twice a day as opposed to once a day. And some of them will be entirely discontinued. You will also have dietary and activity orders requested for you, and you will have follow-up orders. So, this will tell you they want you to see your primary care physician typically within 1 to 2 weeks after your discharge. So that's the who and then when, as I said. And if you have specialists that you also need to follow up with, depending on what your admitting diagnosis was, so be it. Will you have any other tests that you need to set up? So if you came in for a cardiac issue, are they ordering you Ziopatch or Zeopatch? And then that will have to be placed on you. So that's a follow-up. And then if they're following you because you came in for anemia and or a GI bleed, will you have additional lab work that needs to be checked, your hemoglobin, your hematocrit before your follow-up appointment with the appropriate physician? Next slide. Okay, at this point, I'm going to talk about, the focus will just be on community resources. And this is primarily, obviously, if you're going to be going home from an inpatient stay. So I'm going to talk about SCIP, which is me, as I mentioned at the beginning. I'm commonly known here as the SCIP nurse. So SCIP is SCCP, and it stands for Sequoia Community Care Program, SCIP for short. So this is a program that's designed to offer services and community resources to allow older adults that are discharged from Sequoia Hospital to recover successfully and independently at home. Now, I do want to say this program is unique to Sequoia Hospital. Working with traveling nurses and social workers from the care coordination team, they have shared with me that in their travels throughout the United States, never have they ever had a program like this at other facilities that they've worked at. Again, it is unique to Sequoia Hospital. So we do have a little bit of bragging rights here. And the short-term program of the SCIP covers a period of 30 days from the date of discharge home, and then it ends. Next slide, please. So the program goals of SCIP are to ensure the continuity of care for patients that are post-hospital discharge, to avoid potentially preventable readmission to the hospital, to enhance patient caregiver family engagement, to empower patients and their families to self-manage their health care, and to improve patient satisfaction and clinical patient outcomes. Next slide. So based on the SCIP target, most of the referrals that I get will be those typically who are 80 and older. They have multiple comorbidities, and their support systems can definitely vary. The target population are patients who have been admitted to Sequoia Hospital or presenting from the emergency department, patients who are identified as high risk for readmission, patients with Medicare as their primary insurance, patients who live at home with limited or no family or community support, patients who require assistance with managing their multiple medications, and it's typically those who have more than 5, and patients who have multiple comorbidities, and typically more than 3. Next slide, please. So how do I, get my referrals to the SCIP program? Is, I think I already touched on this a little bit. I do get them from the hospital setting, from the care coordination team, the case managers, the social workers, the registered nurses. So if they feel like a patient is SCIP eligible and in need of some temporary support services for that 30-day period, they will refer that patient to me. There are 3 very simple eligibility requirements for SCIP. First and foremost, the patient must reside within San Mateo County. They must have a working telephone, obviously, and then they must be 50 years of age or older. Next slide. So my role as the transitional care nurse or TCN is I have the ability to meet with patients, caregivers, or the family at the bedside if appropriate. During the pandemic, that was completely shut down. You know, our infectious disease nurse at Sequoia here did not want me going into patient rooms or at the bedside. And I was told that moving forward, when they got discharged, all of my interactions with patients would be by telephone only. So part of my role is to facilitate home care and help with accessing services and referrals if needed, or if patients are interested in. I also try to help focus the patient on any medication management, and if they have any concerns or questions about their medications. Obviously, medications are important in one's recovery, and if they're on a lot of them too, particularly if they are pain analgesics or painkillers, etc. With the numerous drugs seniors may be on, it can affect their recovery, obviously, and it can cause patients to be at high fall risk, obviously, too, if they're not taking their medications correctly. I also try to help in the management of both their acute and chronic disease states by, increasing their amount of education, especially if it's a new diagnosis and if they have questions. I try to assist them with navigating the healthcare system, which can be very, very confusing and complicated many, many times. Patients sometimes don't know the difference between certain specialties. They need some clarification. They need some guidance on where to go. I also try and help make an assessment and support the patient's ability and encourage them to perform self-care. Obviously, if they have good family support, it makes it easier on their recovery. But at the same time, obviously it can take an emotional toll on both the patient and their loved ones. I try to help coordinate any post-discharge appointments and services, and we'll be talking about that in another slide, in the next slide. So next slide. So the patient assistance services, the following are Sequoia Hospital's, a few of our community partners that we partner with. And through the SKIP program, we can assist in these areas. Number one, we partner with Meals on Wheels to provide patients with meal service. Now, with the Meals on Wheels and through the SKIP, it's 1 meal per day. It's not 3 meals per day, it's 1. If a patient is in need of or wishes, obviously, assistance with in-home caregiving, we have some agencies that we partner with locally to provide the in-home caregiving assistance. Now, this is 18 hours through SKIP to be used over the 30 days of the SKIP program. So I often tell patients it's a use it or lose it proposition. And there's no charge for the 18 hours of the temporary support through SKIP services. I can also make referrals, particularly for medical care. If the patient is uninsured, they are going to need a follow-up after an inpatient stay. Now, this usually does fall to the care coordination team, the social workers. So again, if it's an uninsured patient, the social worker typically will coordinate the follow-up, the initial follow-up care, and try and get them plugged in with a primary care physician, which most of the time they did not have prior to their inpatient stay. And usually they'll get referred to Samaritan House, which again services uninsured patients, and most likely the Sequoia Hospital Patient Financial Services Department will probably have already started an application process for Medi-Cal, which takes a while though to get approved. The other services and partners are adult day services through SKIP. So for example, Rosner House and San Carlos Adult Day Center for socialization and other services through these adult day services if patients are interested. Now with Rosner House, there will be, or there can be, an eventual fee, but there's an introductory period to try out their services to see if you connect with them and if it's something that you'd like to do. And at some point after 8 or 10 trial visits, they will probably charge a small fee. We also partner with emergency alert systems. There are many out there, obviously. We partner with Philips Lifeline for the devices that are worn, particularly for obviously patients who have a high fall risk at home, and obviously if they live alone. And then you, as the Villages of San Mateo County, I'm not aware of how many of you are aware that you are one of Sequoia's partners through SCIP for your services. So if I send a referral to the Villages, I'm sending it, and Sandra Neff, who you all may know, she's the one that follows up with these. And then we also here at SCIP partner with Family Caregiver Alliance, and they work with patients, particularly I think if they're newly diagnosed with dementia, Alzheimer's, stroke, and the patient and or family is concerned about what their disease progression may be like, and they want more education and support services. So Family Caregiver Alliance is one of those. They're actually based in San Francisco. And then finally, obviously, if the patient prefers a spiritual care to our Sequoia department, I can make that referral. And then next slide. And if anybody now has questions for me or Matt, and I can be reached either by phone or at my email. So we're happy to take questions now.
Hi, Nora. This is Sue Santoro. So this is just a Sequoia Hospital program. Do other large healthcare entities like Kaiser have similar programs? Or is this, you said it was unique?
Yeah, well, my understanding, again, as I shared, based on what the traveling social workers and registered nurses who are part of our care coordination team, they have traveled throughout the US, and every place that they've traveled to, they told me that never once has there been any other program like this one here at Sequoia where they worked at. I'm not sure if Kaiser has something like this, and if people are a Kaiser patient, you might want to acquire. Obviously, I'm sure they have community resources, but I don't know if it's handled in the same way as our program is here. Hopefully.
Right. Yeah, I know they do have coordinators that meet with you to plan your discharge, and then when they send you home with home health care, they go through a lot of the same things that are that you have listed. Not quite all of them, but a lot of them.
Right.
But this sounds wonderful.
Thank you.
I wanted to say that Joyce Logan wrote in the chat that this is a wonderful comprehensive program and it covers so many aspects of need. Her question is that it feels like the first 24 to 48 hours after discharge are the most challenging. How is or can that be addressed?
Oh, and is that okay, probably for me, because it's once they get home. Well, this is a tough one, I think, because gosh, I might have missed saying that as I think back. The standard is to try and contact patients within those first 24 to 48 hours once they get home. Now, I have had definitely occasions where when I've called them within that approximate time frame, I do find that so many patients are kind of understandably overwhelmed when they get home. And when they're overwhelmed, number one, as we've all probably known if you've been a hospital patient before, people don't sleep very well. They have interruptions, noises, interruptions, again, depending on what's going on with them, with taking of vital signs, medications. so on and so forth. So they're lacking in sleep, they're anxious, they're frightened, they're concerned about their recovery and any potential prognoses that they have. They have home, if they have home health ordered, which they often do, they're trying to be, the home health agencies are trying to communicate them also very early on in the process. So they're being bombarded with all of these things, and it is overwhelming. And you can imagine, only imagine, if the person lives alone and they really have limited or no resources, it's hard for them to digest all this information. So I try, actually, my preference is to give them a few more days. You know, sometimes I like to reach out day 3 or day 4 when they've been home, to see how they're doing. And sometimes when I've contacted at that point, they're a little bit more open and receptive because, like I mentioned, they've been bombarded by telephone calls with the home health agencies trying to connect with them and set up appointments either with a nurse, the physical therapist, so on and so forth. And I've even had some patients, you know, tell me that they prefer that I don't communicate with them. For sometimes the longest I've gotten requested is, please wait for a week before you call me, because then they feel like they have a better idea once they've settled into their home environment and they're a little bit more familiar again, and they've had a little bit more sleep to figure out what their needs might truly be, and if they do want to take advantage of any of the skip resources at least. So it is a challenge. Now, usually and hopefully, you know, when the hospital nurses from the care coordination team side, they're coordinating the planning when they get home, they will talk about the skip, especially if they think the patient can benefit by skip services. And when they talk about it briefly, I have brochures that they have, and they will give the patient our brochures, and it has my direct contact number, you know, but knowing that I also will be contacting them because they will be sending me the referral. So if they want to, you know, be proactive and take the initiative, they can sort of obviously call me if they feel they have more of an urgent need and they do want to get referrals going. Hopefully that answers the question. And I think the other piece of it is if they really have major concerns or pertinent medical issues, certainly, as I say to patients, and they know if they do have a primary care physician, you know, they can call them directly. The staff should know them if they've been their patient for a long time, and obviously relay any medical, immediate, more medical concerns that may be more pressing or urgent directly to their primary care's office. Now, there has been occasions sometimes too where I've intervened because the patient has told me that they did leave a message already, but they haven't heard back. And sometimes maybe it's 5 hours later in the day and there is some urgency and you know, worry on that part of the patient, whether they're going to get a response by the end of the day. So sometimes I have intervened for that patient, and I will leave a message as the community nurse. And so far, I'm going to say successfully, that seems to have gotten them the answer more quickly, and then the office will call them. Anything else out there for me or Matt?
Okay, next, I think I've got Chanel. I have you ready to go. Thanks, Chanel.
Get off mute. So I'm ready. All right. So good morning. I'm Janelle Jabrowski, and I'm privileged to be the most recent member to join the Sequoia Health and Wellness team. And my role here is as a community health nurse and educator. And just in line with everything that we're talking about today, long-term success involves health education. And my focus is primarily prevention, heading off things before they're a problem. So I bring to Sequoia Health and Wellness 14 years of community health nurse education experience. My passion truly sits in my entire career with prevention. So to that end, I like to approach my work by starting where the individual or the group that I might be teaching is at in their life. And that is a good starting point to build a relationship. I believe that we learn better by being actively involved in education. So what that looks like is my role would be to provide health, medical knowledge and framework. But equally important is the attendees of the class or my patients' involvement by sharing their own life experiences. So it's a two-part thing, and I think the theme underneath everything we've talked about so far is relationships in medicine are meant to be collaborative. So yeah, all right. So can you go to the next slide, Tricia? Okay. So the question is then, what do I offer? And part of that, we'll just go to the next slide. In my new role here, I offer health tips and pointers. One of my primary focuses right now is offering community health programs that are classes that are 30 to 60 minutes long. And the focus, my specialty really is in heart health, diabetes, and the biggest part is lifestyle as medicine. So I have been kindly invited by Devora to come and do a talk for Coffee Connection next month. She's asked me to do a presentation, which will be experiential, and that's going to be on managing stress and through mind, body, and spirit. And in addition, up and coming is going to be 6 to 8 week education series that I'll be facilitating. And those will initially be focused on diabetes and fall prevention. So I want to thank everybody for, thinking about the future and long range education for wellness. And I hope to see you next month. Thank you. Next slide. That's my contact information. And are there any questions for me?
We're looking forward to your presentation next month.
Great, great. And so am I. Thank you.
Great. I think that was all of the presenters you guys had, right? Okay, yeah, thank you so much. That was great. Well, if there's no more, are there any additional questions for any of the speakers? No? Okay. Well, I really appreciate this, and I know that a lot of people will be enjoying watching this as well. And thank you so much for all of this great information and for being with us today.
I'm going to put my email in the chat. So if anyone needs to contact me with questions later, that's something they think of. Okay.
Perfect. Sounds good.
Devora, thank you for doing this.
Yeah, I'm so
Thanks.
glad that we
Yes,
could have this session today.
thank you. Thank you all. Very, very well planned, lots of really good information.
You're welcome.
Thank you.
Okay, well, Janelle, we look forward to you next month. And thanks again, everybody. Really appreciate it.
Okay.
Okay, bye.